Good morning, friends. Welcome back to my YouTube channel Medical Classes by Dr. Srinidhi Kumar Acharya. Don't forget to subscribe my channel and also please give your valuable comments. And you can also visit the playlist. In the playlist, I have provided almost all the topics in a very systematic order. You can make use of it. Friends, since last 5 classes, we are discussing about nephrotic syndrome. So today also we will continue the same. In the pathology, what happens in the first stage, what happens in the second stage, we have seen. Today we will see what exactly happens in third stage. Okay, so now in the second stage there is it's called as non-selective proteinuria because more and more proteins are going along with albumin. Globulin is also going. Okay, now in the third stage there will be still more injury. The injury is going on continuously going on. If it is autoimmune, continuously the injury is progressive, and there will be still more injury at grade 3, and there will be albumin going out, there is globulin going out, and it is called as non-selective proteinuria. We know that. And there will have more albuminuria compared to the previous two situations, as the injury will be more and leaking will be also more. Okay, in this stage, third situation, compared to the first and second situation, albumin is going more because the slits are more bigger. Okay, so compared to the previous situations, the albumin loss is more. Now, if this albumin loss is more than 3.5 grams per day, if this albumin loss is more than 3.5 grams per day, then there will be more presentation of the symptoms. Compared to the previous situation, now there will be more presentation of the symptoms, and now the pathological changes starts with the further complication. Pathological changes start with the further more complications. When patient comes to you at this stage also, it can be better treated with Ayurveda management with some strict dietic modulations and some of the rasayana drugs. That we will see later. This is just a glimpse that I have given. So when the patient reaches this particular stage, third stage, so what exactly happens and what are the clinical symptoms which are arising? As proteinuria increases now, the liver has to work more and it needs to produce more and more protein, because whatever the protein which is produced by the liver, that has been lost through the urine, like albumin, globulin, etc. Albumin, globulin, both are produced from the liver. Now liver has to do some other alternative method for that to correct the protein balance. So what it will do is, now usually liver capacity to produce the protein is 10 to 12 grams per day. Per day, a liver can produce about 10 to 12 grams of the protein, but still only loss in the urine loss. But when the protein is lost in the urine, about 3.5, more than 3.5 grams. See, usually 10 to 12 grams will be produced by the liver per day. But per day, when the protein loss is more than 3.5, now the liver become alert. Okay, now it assumes that, or it senses that yes, something bad is happening, now I have to correct it. So, okay, so now actually the symptoms start, because when the protein loss is more in the glomerulus, the cells of the proximal convoluted tubules will absorb, and the catabolism of these molecular size proteins, and only remaining will pass through the urine. Now this is very important, we need to understand. In the urine, 3.5 grams of protein is going on. That does not suggest that only 3.5 gram is going out, because when the protein is lost, the filtration happens through the glomerulus. Now that glomerular fluid, filtrated fluid, is coming to the proximal convoluted tubule. Now what happens, as soon as it reaches the proximal convoluted tubule, the proteins which are present in the urine, so that will be get absorbed by urine or filtrate fluid in the lumen. So that will be get absorbed by, that will be absorbed by the proximal convoluted tubule cells. Okay, cells which are present in the proximal convoluted tubules, and they take that protein, degrade it, okay, and convert them into some other amino acids like that. Okay, now what happens, this gives a misinterpretation of the protein loss. See, we are only calculating the protein loss in the urine, okay, but actually the filtrate contains more amount of the protein which was not coming under which is not coming in the urine analysis, because about 50% of the proteins are get absorbed by these proximal convoluted tubules and it was degraded. But if you only look into the investigations, it is showing only 3.5 because remaining amount of the protein is going through the urine, isn't it? 50% is already destroyed, but the protein loss is 100%. 50% which is destroyed by the PCT and 50% which is present in the urine also. So therefore, if although body liver produces about 10 to 12 grams of protein per day, when the urine protein loss is more than 3.5 gram, it is almost equal to a loss of about double of that. So therefore the symptoms start. I hope you understand this. So although it is only 3.5 grams day which is appearing in the urine, in reality there is more loss of the proteins through the glomerular filtrate. Okay, so when it is more than 3.5 grams, the symptoms usually start, and it is called as heavy proteinuria. Okay, so when protein loss is more than 3.5, so it is always called as heavy proteinuria. So plasma proteins perform many functions, and one of the main function is maintenance of the plasma oncotic pressure. Okay, now this is very important. The protein has been heavily lost in the urine. So when the protein amount is less, the protein is very important in the bloodstream also, because we know that in the blood inside the vessel, two types of pressures are there. One is hydrostatic pressure, and another one is plasma oncotic pressure. Plasma oncotic pressure is maintained by these proteins, especially albumin and globulin. Albumin plays a very important role in maintenance of the plasma oncotic pressure. When such a albumin is lost, now plasma oncotic pressure will get affected, and as a result there is an imbalance between the hydrostatic pressure and plasma oncotic pressure, and now this, because of these pressure changes, the fluid which is present inside the vessel will be get displaced into the extracellular space, and that leads to the formation of edema. So this is how the edema begins as a response to protein loss. Okay, in this stage also it can be better treated by Ayurveda management, and we have to go for some strict dietic modifications and modulations, along with the rasayana drugs, and some intermittent steroids may be required at times. Okay, to be frank, okay, at times maybe we have to go for some intermittent steroids in a low dose. Okay, with a low dose it is manageable if you are going along with the Ayurvedic drugs. So what happens when the disease reaches the next stage? So as we know, when the blood moves, this is the same consequence of edema. Okay, as we know, when the blood moves in the vessel and then it turns into the capillaries. In the capillaries there are two ends, arterial ends and as well as the venous end. This is what actually the detailed description of what I explained previously. Okay, and in the arterial end the blood hydrostatic pressure is more than 40 mm of Hg, and in the plasma oncotic pressure is 27 mm of Hg. This is the arterial end, and in the interstitial area the hydrostatic pressure is less, that is 15 mm of Hg. So what happens? The fluid moves out of the capillary into the interstitial place from a higher pressure area to the lower pressure area, and this fluid, which contains nutrients, minerals, oxygen, etc., will nourish the cell and get back to the capillary at the venous end. So this fluid is less in proteins and it contains more waste products. So now at the venous end, inside the capillary, the plasma oncotic pressure is more and the hydrostatic pressure is less. So fluid gets sucked inside the capillary and drained through the veins. This is exactly what is happening in normal condition. Suppose if the protein loss is more and protein amount is less, then at the venous end what happens? Fluid is not able to reach back into the vessel. So it remains in the extracellular space, and that leads to the formation of edema. So when the protein level is significantly low, as in case of glomerular injury, then the plasma oncotic pressure fluid cannot return back at the venous end due to the low plasma oncotic pressure at the venous end of the capillaries, leading to collection of the fluid in the interstitial area, which is called as edema. Now as it happens all over the body, it is generalized edema and very severe, so then it is called as anasarca. This is also called as anasarca, generalized anasarca, when the edema occurs all over the body. Edema of the renal system initially start at the eyes. This we have to understand. Any edema which is occurring because of the renal system, the first presentation is in the eyes or the periorbital areas, and then it spread to the other parts of the body. Whereas edema which is occurring because of the cardiac causes usually start in the dependent most portions of the body, like ankle, etc. Okay, whereas edema which is occurring because of the liver pathologies like liver failure and all, usually it is ascites. Presentation is ascites. So reason why there is periorbital edema in case of nephrotic syndrome, which is basically a renal disease, that in any renal conditions you will have periorbital edema. Okay, so that is face edema in the facial area, that is more, or periorbital area is more. Not only nephrotic syndrome, any other causes where the kidney injury is there. Okay, renal issues are there. So the first symptom which occurs as a edema is in the face. The reason is the tissue in the orbital area is very loose and skin is poorly attached with the underlying tissue. So easily there will be collection of the fluid. So collection of the fluid is more as it is accommodate extra fluid without raising the local pressure. Without raising much of the local pressure there, local skin pressure there. So it can accommodate more amount of the fluid. So fluid tends to move there. So this edema is again pitting type of, this is also a pitting type of edema. Okay, so this is how the edema start and its pathology. Rest of the things we will continue in the next class. Thank you very much.